topic would be this: how teaching has made me a student again. But because she has requested me to talk on that, I'll just share a few brief slides, a 5 minutes presentation on that, because I don't have anything to add, because I don't know how the YouTube algorithm works, technicalities of it. Nothing I know about it. So I really can't tell much about it. So just a brief thing, my YouTube journey, and of course, when you start, you really don't imagine or anything that where you're going. So I started in 2015, 10 years back, and the journey has been good, but I really don't know, actually speaking. Apurva, you people should tell me why this. I don't know what the viewers like. So if you ask me to tell about this, it's too, what do you say, embarrassing me for me to tell how I did this, why did this, and why I got this 1,000. I really don't know. Frankly speaking, I don't know. I don't know what the viewers liked about it. I really can't comment about it. It just, with what I thought, the videos are made in such a way that if I am a beginner, I try to know what struggles I had, what doubts I used to get. In that context, I used to make video. And now, for the last maybe few years, when you're training these young surgeons, hand-on fellows, then we get new insights. And now we're getting better ideas, like what difficulties they are there and how do we address them. There's the only intention of making those videos. Apart from that, I really cannot clarify like what the video viewers really liked or don't like about me. So then I just say thank you for liking them. So at the flip side of it, okay, if you just there's something wow about thousands, nothing is wow about it. I don't know why it is wow about it. It did not, filmmaking did not help me in many ways. It did not grow my practice. There is no advertisement of my practice there. I did not make any money because it took a lot of time and money, in fact, from me. Okay, and I could have focused on growing my practice. I should have become more financially intelligent, help grow the hospitals. But in personally, if I just look back, there's some of the things which I experienced. What did I do? Sit and do videos. Okay, nothing. So these are all the drawbacks which we have with that. But I liked filmmaking and I was just passionate about teaching. That was the only thing I was passionate about. That was the only intent. Like just, and in the process, what happened? It just, internet gave me that access. We didn't have. You don't have to be a medical college professor to teach nowadays. That is the beauty of modern era. Internet is there, and if you're passionate about teaching, you just teach. That's it. And there are no time limitations like 5 minutes, 4 minutes, 6 minutes. You can take your time. You can explain in detail, and you can have you can teach as you wish. So that's what I enjoyed. The heartening thing is I could reach so many budding surgeons across the world and have a little impact. That's what I'm just thankful about it. And what is the challenge and also the driving force? What is the challenge for this and the driving force also? Sometimes I feel it is tiring to do this because you have a hospital to manage, you have your own patients to take care of, and you have your day-to-day activities, all those things. But so whenever I travel across and the candidate students just come and tell two things. Number one, they say thank you for doing all the job. But the second most important, which continues to be the driving force, is they keep telling me this: don't stop doing what you're doing. So this is the only statement which continues to motivate me to do this. Otherwise, there is another. This motivation is good enough. That's what I should say. Apart from this, Dr. Apurva, I don't have anything else to talk about my journey because I don't know how the YouTube algorithm works, why there are subscribers so much, because I don't never tell like, share, subscribe, nothing. So that I don't know. I don't understand this principle of YouTuber also. Okay, I'm surprised I can like, share, subscribe, something will be there. So there's a thing. So I really comment anything more than this about this. So sorry for that. And I would like to just take you to some topic which I am very fascinated about. So I was thinking, like, when I said I can't talk about it, let me talk about any other alternative topic. And I was surprised. I was thinking, what should I talk about? What should I talk about? Last time, Venkatesh sir said, what's last time your talk was surgeons are made and not born. Great. You can talk something about that. I thought it would be repetition. Let me flip the coin and say how teaching has impacted me. So I'd like to flip the coin and look, it's a sort of an introspection, what it has helped me. So because you are all the future of ophthalmology here, okay? All of you are the future of ophthalmology. You people are going to do cataract surgeries on us. So it's better that you are empowered with all the surgical skill and knowledge. That is my little bit selfish endeavor in this. And I also tell you, congratulate, you are probably in the best field of medicine here. If your brother, sister, daughter, anybody is thinking whether to join ophthalmology or not, this is probably the best field one can ever have. You have medicine, you have got surgery, and there's no better treatment for any disease other than cataract. You can't have a more thankful patient than treating on a cataract patient. So in my eyes, this is probably the best specialty one can choose, and you already chosen. Congratulations to you. So my topic, I really surprised when I thought what to talk. This made me. I thought how being a surgical teacher has helped me to be a better student. So this is what I thought just maybe 1 week back when she told me to talk about this. So this is a question for all of you. When do surgeons stop being students? After residency, after fellowship, after 5,000 cases, 10,000 cases? Take a moment, reflect, and opine. How many cases are required actually to say, okay, student, I'm not student anymore? Okay. So, pardon me? Excellent. So the traditional belief, experience is equal to excellence. It is true in parts. I don't deny that. More years, more cases, fewer mistakes. Remember, more cases are always good, but definitely number is not everything. So don't be in that rat race of numbers. Numbers are good, but beyond some time, beyond at a certain stage, numbers don't matter. Okay. So the traditional thinking is like this, you have a linear myth. You are resident, you become expert, and that's the end. On the contrary, I'd like to flip it and say, you first learn and then do things, then you practice, then you start teaching. When you start teaching, what happens is you relearn many things. You relearn many things. And this is actually responsible for refinement of your skills. And then you go back again to learning, and again you teach these new things. And then the cycle continues. Learn, relearn, practice, and again teach. So in my early years, okay, I was just focused on efficiency outcomes. I shouldn't have any complications. My surgery should speeden up. That was what we focused. Typically, when you're in all private practice, individual practitioners, our focus is typically on these things. But teaching entered my life. Maybe we start presenting in conferences. Initially, we start like that, and then we live surgery. And YouTube happened to me 2015, but it was inactive. Predominantly, it became active only during COVID because there was a time when I had to go back and review my old videos. Dr. Venkatesh said COVID was a golden time for him to introspect and develop new modules for patient care, patient management. And I had that opportunity to see my videos and thought that this will help many people. And then we have the fellows and hands-on training. During all these things, what happens? You are getting an opportunity to go back and review our own videos because we had time. And that taught me something else. Initially, I thought I was teaching surgery, but actually surgery was teaching me. It was the other way around. When you go back and look at it, it's like I'm in a false world that I'm teaching surgery. No, surgery was teaching me. Let me explain this point to you. So there is something called intuition and there's something called understanding. When you're operating for self, you're operating on your own, okay? You have certain intuitions, you've got certain habits, certain styles. You keep on continuing with that without any explanation, clarity, or system in place. So when you start teaching for others, you have to answer every step, every question, and every way you're doing. So intuition is replaced by explanation, habit is replaced by logic, and style has to be replaced by system. This is the go. So, what is teaching actually? What is teaching? If you can't explain it simply, you don't understand it well enough. Remember this. If you ask a question and somebody is not able to tell you properly, the answer is that person doesn't understand the subject well enough. If you're able to simplify everything, then only you understood everything. So what is deconstructing intuition is, I do a surgery in a particular way. What does it mean? You have to analyze the why behind every move. Why you're doing this? Why you're resting your fingers like this? Why you're holding this? What is the logic behind it? So, and when you start teaching, you have to teach techniques in such a way that they are reproducible by most average skilled surgeon. We say, no, it works in a particular eye, it works in my hand, it works in your hand. No, you have to design a technique or explain it the technique in such a way that most average skilled surgeon should be able to grasp it and reproduce it. Okay, then it is not, if your technique only one person can do, then there are two things. Either he's extraordinarily brilliant nothing, or he's not telling you the small secrets which are required to ensure that that functions well. There are only two things to that. So ensure that you're explaining the technique in such a way it is standardized and can be reproduced by most average skilled surgeon. You know what? The camera is your greatest critic. Okay, you can't cheat it. You can't cheat it. If you're honest enough, you can be the best teacher just looking at it, because camera is telling you everything. If you just sit and see a recording and everything, you just review your videos, you can be your best teacher. And when you review your videos, you start to analyze every small step, and then you start to add why you're doing this, how it is to be done, and at what time it has to be done. So remember, camera is the greatest critic. So this is what I thought, actually surgery was teaching me. So teaching exposed what I did without understanding. This is how I do it. This is how I do this. This is what commonly you teach about. Many things this session, they're just done. This is how I was taught. This is another common excuse. This works for me. But when a resident asks, when a fellow asks, no, why exactly here? Why not earlier? Why not this way? Then suddenly surgery demands clarity. Okay. Surgery demand, a teacher has to have clarity. You have to do this way, because if you do the other way, this thing is going to act like this. That's the reason why you have to do this way. This clarity has to be there with the teacher. Then only he can convince his fellow or a resident. So habits have to be replaced by clarity. I'm just habituated doing this. No, you have to have some clarity in why you're doing this particular thing. And surgery teaches you what you truly understand and what you don't. If you're really honest in this, you really come to know, okay, I really am good at it. I'm not good at it. I need to work on it. Either it could be a step or understanding of a principle, either way. Just look at the monitor and it'll teach you everything. So intuition is turned into conscious knowledge. And this is another thing. We develop muscle memory. Okay. I do like this. I do like this. But muscle memory is not teachable. You want to teach to a resident, you do like this. How can you teach muscle memory? You're doing it since long. You have developed that competence, which you're unconscious about. You're doing this. But now the knowledge has to be transferred to your younger colleague. You have to break down that step into things which are repeatable by them. You slow it down. What I say in every technique when you're playing, try to break it down into multiple small steps. Simple thing like, you just chopping, direct vertical chop. You analyze it, you structure it. And teaching forces us to study our own hands, own timing, even our own decisions. So this is how, let me just show you by self-observation how you do. Now, this is the yesterday's Phaco chop. I just added it here. If somebody you want to explain how to do a direct vertical chop. So the trainee has to practice this in his mind and his head multiple times before actually he does it in surgery. So actually, you place the chopper in front of it and then you go vertically down and then do it. So if you can just spell it out like this, it could not be, very comprehended by the trainee. So what I would like to know, you just practice this. What I'm doing here is my right hand, the right side is the phaco probe. It is holding the nucleus and it is lifting up a little bit. It's not going down. It is lifting up a little bit. And then the chopper is in place and then it goes down and then laterally. When it's going down laterally, the right hand with the phaco probe continues to be up. It cannot go down. If both of them go down, you're going to put stress on the posterior capsule and the bag. So this has to be practiced. Right hand holds up, and then you do it. You do it 100 times, 500 times before actually doing the first, your clinical chop. So the second aspect of it, when you have students, they also act like a moral compass. You have to be in a certain way because everything is reflected. They copy your hand movements, they copy your shortcuts, your hesitation, your panic, and your calm, everything. So this helps us to grow as a people. The students also are our moral compass. Okay. So they know how you behave when you're in panic situation. They would have in a complication. They understand everything and they imbibe those qualities without you telling anything. So it's important for us who are supposed to be teachers to always define what is the right and what is the wrong way and follow this path. They cannot be in between, because you are responsible for the next generation who are observing you subconsciously. So it is like a mirror. The student is just your mirror. He's going to copy everything, your good things as well as bad things. So it's important for us to identify what is not good and try to be on the right track. So the everything, how you react to a complication, how you panic, all these things, the student is going to imbibe in them. So there's another thing. Every time a student struggles, we had to ask ourselves, is this their limitation or my unclear teaching? Are you getting my point? Sometimes what happens in a particular step, the student is got stuck. You're not able to get through it. Some students pick it up early, some students don't pick it up early. And so just try to, some of the common things which we encounter, I just tried for an example sake, I'm telling you. See, in our hospital, we have got a very limited amount of fellows, only 1 or 2 fellows per year. And maybe short-term trainees will be one time at a time. So very small number, unlike Arvind or something. So and we are only 2 trainers, myself and my wife. So when we see, sometimes we struggle also, like, if this particular fellow is having a difficult in particular situation, what? So we try to compile them. And like yesterday, I saw a beautiful graph, which Dr. Venkatesh shown, like, they've graded this complexity of these cases. And if this complexity of case, somebody has a complication, then you go and evaluate. Now, something like, FACO beginners, what we found was, let me just show you a video. So this is a small clipping which just documents what difficulties the beginners have during sculpting. So traditionally, we believe that sculpting is probably the most simplest way or simplest step in phacoemulsification. And we begin with this. And what difficulties which we have encountered, I'm just trying to highlight here a few of them. And do we have solutions? I was asking, if the student is not learning properly, is it because the student's problem, or is there a gap in the way we teach? That's what we want to analyze. And can we find some solutions for that? So one of the most common thing, pushing at the nucleus. This is very common, and many of you would be trainers here. I think the biggest, contribution of the trainers is they have to sit through and watch all this torture little which is happening. It will be very frustrating for an experienced surgeon to go and see these clips. Now look at these clips, and I want you to just comment like what is going on here. The surgeon is trying to sculpt, okay? So literally it is being pushing at the nucleus. The rule is that ultrasound energy has to do the job rather than with the hand you're trying to push it. You want to sculpt it with the hand, not with the ultrasound energy. The entire bag would be moving now. The entire bag would be moving. So this is the first mistake most of them do, because there is a lack of coordination between your foot and your hand and the way it goes down there. Second, this is very common, eyeball pushing. When you try to sculpt, the whole eyeball is going to go down in the other direction. The entire eyeball will be turning down, and the distal part you're not able to visualize properly because the eyeball has turned down. This is the number one difficulty most people have when they're doing the first 20 phacos. And this is, you're doing a trench. The trench will be irregular. It never become a straight line. It's always irregular. It goes left, it goes right. And we want a small narrow trench, in where we have a wide trench. So you can see the plus has become a cavity there inside now. Actually, there is no, very difficult to find a plus there. This is what all the common difficulties which we have. So we were struggling to find some solution to measure this, because we always felt that, sculpting shouldn't be so difficult here. So what is the problem here? So maybe a year back or something, we switched strategies. So what we recommend now is the surgeon, the trainee, is holding the phaco tip with both the hands. There's no second instrument inside the eye. These fingers are stabilizing on the patient's cheek, forehead, the table. They're getting some instrument, and you can see the movement of the phaco tip is so controlled now. It is much more controlled. Initially, for them to get used to it, it used to take some 30, 40 cases. Now, by 10 cases, they're getting an idea like how to trench. This is a small increment, what we've done. And for rotating the nucleus as well, you don't have to use the second instrument. You can just use the same instrument to rotate. So this is what we learned in the process of teaching. Like why these people are having so much difficulty doing sculpting. Sculpting is supposed to be very easy. No, we would have learned from 20 years back, we would have forgotten what difficulties which we have on. But when we encounter with these beginners, you have to do this. The second problem which we see, this surgeon is trying to sculpt. You can see the phaco probe is moving, ultrasound energy is on, but they're empty. The nucleus is not being engaged at all. The surgeon is probably scared and he's just going through and coming down. Going through, nothing is getting cut there. So it is just going. And you know what? Each trainee will have his own unique difficulty. Okay. All trainees are not the same. Every fellow has got a unique difficulty. And I think it's a responsibility of the trainers to sit and try to figure out what is difficult here, why is it having difficult, and then try to provide some solutions in this. So now you can see this is a very dense cataract, but the pushing is still there. But because the surgeon has now understood what power to use at this grade and able to do, and you can just wanted to show you that the nucleus rotation is possible with the same instrument without doing without rotating it. So you can without using a second instrument. Basically, what happens for the brain to get adapted to the four limbs, right hand, right foot, left foot, and the eye and auditory, takes some time for the surgeon to develop. Until then, if you can minimize these, what do you say, intimidations by using just one hand, he had one limb is taken out of the action there. So that gives a better control. So these are all, teaching is also a learning curve. We keep on learning like what is easy for them, what to difficulty. And our job is to simplify things, just like how we see. And we have to ensure that the surgery is at no cost, the safety is compromised. That is the primary goal. And in this process, without compromising safety, can we make the step more safer? And that is what is the role of the mentor, refining the technique. So remove non-essential elements. What did we do? The second hand did not have any much role there when you're doing. And because the second hand also was active, the surgeons, the trainees were finding it difficult to coordinate because all the four limbs are in action. So just take out one thing, trying to keep it as essential as possible. And that has gave us good results. So what it does, teaching, it helps us to redesign everything. It's not necessary that how we learned, everybody else should learn the same way. It is not necessary to that. So identify what could be the right step sequence for this generation. Explain to them what risks can encounter, and they'll be taught about this risk much before then. See, now this generation of surgeons are going to create lesser complications during their learning curve than our generation, because the trainers are already aware, so they can making this generation aware of what are the risk possibilities, and of course supervision levels, and then you have to have the right feedback. So in our institute, what we're doing, identify. So how do we train? Now this was a difficult choice for us. We decided our goal was to identify what are the easier steps in phaco and what are the more difficult steps in a phaco. So that when the trainee is going to this program, he has to have a very, what do you say, less scary curve. Like, whenever you have a complication, you really the confidence level goes down. And in surgery, confidence is the name of the game. Okay. Confidence is the name of the game. If you're confident, then only you can progress to the next step. So our job as trainers to ensure that the confidence is maintained at every step. So you have to design programs in such a way that their confidence levels is maintained. At the same time, they're learning also. So we decided to identify what is the easiest step and the more difficult step. So we reviewed the last 50 trainees and fellows who what are the difficult, we graded the difficulties, what step is more difficult for them. So we found out that quadrant removal is the easiest step. Quadrant removal is probably the easiest step. Next time, contrary to belief, sculpting was not easy in our study. Sculpting was the next easy step. Not third would be lateral separation or quadrant separation, and last would be chopping. Okay, so this is what our study showed, that this is how the quadrant removal was. Why was it easier? Because you're just pulling the quadrant out of the bag, you're in the central safe zone, and then you're doing it. There is very limited, what do you say, movement of this non-dominant hand, because the separation is already done. You're just emulsifying with the quadrant. And the incidence of complications, if done rightly, was the least in this stage. While sculpting, you're more likely to cause a PC tear. While lateral separation, you're going to cause risk of causing a PC tear. Quadrant removal, you're in the central safe zone, and the stress on the candidate to look out for hear the noise and all those things is much lesser. This is the easiest step, what we have realized. Then comes sculpting, then come lateral separation, and last would be chopping. Chopping because multiple things are involved: right hand, right leg, left leg, and your audio, the ear and the eyes have to work all together. So our mantra was to start with the easiest. So when a fresh fellow comes, we do the, like, it is something like you start, we call it a Faco reverse module. What do? We chop the fragments, give them the fragments, start with the fragment removal. This is how now we're training the fresh one. Start with the easiest one. Once you're getting used to the foot control, the depth assessment, you should know what depth you are. Everything that is possible only when you do quadrant removals. Once you've done a little bit of quadrant removals, then you start giving trenching. Then you do lateral separation. And last would be chopping. And this Faco reverse module has helped us. And coming to lastly, the complications, like what has changed my relationship with complications? Initially, complications are events to be managed. That's what it were. But now it has changed. When you're in teaching somebody, complications become lessons to analyze. Okay, every complication, you analyze them in detail so that you try to identify those early signs which become teachable moments. You try to grasp that particular moment when it happened. Yesterday, we're doing that FACO analysis in that yesterday. We're trying to pause the video and see exactly what happened wrong. Okay. So now our mentality is totally different. We're not interested in managing now. Of course, we're interested, but more importantly, our focus is on prevention. If we can detect these subtle signs early, probably you'll be able to prevent these complications next time. So the everything is shifted now totally from management to prevention. Ultimately, our aim is to have one day zero complications. That is what our goal would be. So surgery, what does it teach us? It taught us safety by forcing us to explain risk. So we explain this happens, risk is there, identify those risk situations, and then enlighten our students about this. And lastly, humility. Okay. Complications do happen. And the moment, the day you say you're on top of the world, you feel having done a very complex case, and life is a circle. Next day, you're going to fall down. And that is what we learn. And that is what we teach you as well. And students are all observing this. They're also there with you when you're on top of the world, and they're also there with you when things go bad. And you also have to teach them how to handle this situation as well. And in this process, they also realize that humility is probably the most important virtue one has to have a surgeon. There is no role for ego, okay? And this keeps the surgeon honest, humble, and alert. So leave your ego at the door, okay? And if you make yourself the most important critic, probably that is the most important, powerful surgical mastery tool one can ever have, okay? There's no ego should be out. The moment you say, I know everything, then that is the end of learning. So what did we realize over a period of time? Okay, we thought we're improving student surgery, but actually in hindsight, I was refining my own thinking and one question at a time. So teaching forced us to rethink fundamentals, simplify complexity, build safety into every step. Say again, the surgery was teaching me, not the other way around. Now let us flip it. How does teaching help the residents learn faster? It forces clarity. There's no question of, intuition, habit, style for them. Because now we are telling you, this is the reason why you have to do the step like this, because otherwise this happens. Because now there is a clarity. So you're already fed with clarity beforehand only. That is the responsibility of the teacher. You don't have to waste 25 years of life to develop that clarity. It is there for you on day one. That is the advantage. So you don't have to do any blind imitation because you have a logic here. And because the surgeon has already experienced so many complications and he is in the process of building safe habits, it's easier for us to understand and build these safe habits earlier. And lastly, you have to become a reflective surgeon. It helps you to become a reflective surgeon. So this is a symbiosis of generations. Okay. What do the students gain? Experience. You don't have to spend 25 years to gain the knowledge of 25 years. You can get studied in jiffy. You're alert about the safety rules, and you are also now going to be a mentor in the future. And what does the teacher gain in this process? Okay, he tells us a different perspective. He views the world from a student's eye, and then he is thrown with new questions, and then he's going to find solutions. In the process, his technique gets refinement, his understanding gets refinement. So who is the ultimate beneficiary? After all this, we've got better teachers, we've got better students, we've got safer surgery, and ultimate goal is to have a happy patient. This is our ultimate goal. Why are we working all this? Why we have to teach? Why you have to learn? Remember, the ultimate goal is this: healthy patient, healthy vision, and a happy patient. This is what our ultimate goal is. So, message to the senior surgeon, okay? Teaching is not an obligation, okay? Don't think that it's an obligation. It is, I think it's an upgrade. And to achieve to true mastery, teach it, okay? So, you're all going to be senior surgeons soon. And remember this quote: to achieve true mastery, we need to teach. So, teaching forces precision, understanding, and simplifies complexity. To conclude, teaching did not make me a master, it made me a lifelong student, and that made me a better surgeon. This is probably the take home message for all of you.